I think when you look at muscle strength in a muscle disease, it kind of makes sense that you're looking at what the problem is, and I think the clinical interpretation of muscle strength, given all the other translational issues between that and walking and everything else, it's still a reasonable measure that I think we can interpret that intelligently. That means something. But muscle strength is just one type of physiologic measure. There's certainly a lot of others, and which are not really how a patient, feels, functions, or survives, but is still would seem to be meaningful. But yet, depending on what the history has been, there's some that may be easier or less or more difficult to get some of these things used in actual clinical programs with rare diseases. So, as an example, I put up the MPS I story, which is a very complicated disease because there's so many different tissues that are affected, and all these tissues have a series of things you could measure that are going along, and there certainly might be chronic outcomes as well, but if you're doing this kind of rare and heterogeneous disease, it becomes extremely difficult to do them long enough and to have enough patients. But you can't do some of those clinical outcome measures, just wouldn't really, the probability of powering them is very, very, of populating a study with sufficient power is the problem. So you're stuck more in this space where you're looking at physiologic measures, but these are also considered, in a sense, surrogates. Now, some of the surrogates for some of these functional measures have been accepted because they have been used, and so we heard about the 6-minute walk test, or now people are talking about muscle strength, and there has been some acceptance of muscle strength as an endpoint. Forced vital capacity also has been used as endpoint, but that also can be looked at as a surrogate. It's not really a pulmonary functional outcome, it's kind of a test of how your lungs are functioning. And I think one of the other things that is important is understanding that the size of change has some impact on whether it's considered meaningful or not. So if the change is small, it's now even more like a surrogate, whereas if it's large enough to be more obviously clinically meaningful, for example, the forced vital capacity FV1, if it's a minimum 11% relative change, that's considered in the pulmonary field a clinically meaningful change. But if it's a 2% change, then it becomes more of a surrogate of improvement, but is it really in and of itself an improvement? I think the challenge comes is that certain tests have had some history and they've been used, and so there's sort of a regulatory precedent for using them. But there's a whole bunch of other measures that have not been used as endpoints, and now how do you, but you don't really have access to them, you have to create the case for them and in some sense qualify them as surrogates. Now I put some here in the MPS I field. I had the challenge of trying to develop a clinical program, having never developed a clinical program before. This is in 1997. And so I looked at everything that's wrong with this disease, what are all the problems they have, and then figure out what could we measure for each of these things. But I thought of it as more as a physician measuring a patient rather than someone doing clinical development looking at outcome measures. And we assumed we were going to have a very small study. We looked at a series of things. And one of the things that was important in these patients, for example, is joint stiffness. And they get a lot of synovial storage. And we showed in our enzyme therapy that the synovial storage is cleared. And synovial storage leads to joint stiffness and limitation of movement, which would seem clinically meaningful of itself. And the typical way it's measured is by looking at range of motion. There's also activities of daily living that you might use, but which are much more imprecise, more non-parametric kind of measures, and a little bit harder to quantify, but range of motion can be measured accurately. And we did do that, but the challenge is using range of motion as an endpoint is not readily accepted because it's, in a sense, a surrogate. It's not a really clinical outcome in and of itself. And yet, it is an important measure, and patients will explain that. But how do you capture that in a trial, in a small trial? Mark, I can see we're going to get you going. I can see, so this is good. But so we weren't able to use range of motion, although I think it was important. But it is an important thing. And in this disease, we had in the first study looking at younger patients, we had something like a 20+ degree improvement in range of motion. And 20 degrees is, going from, let's say, 90 to going to 110 is the difference between being able to comb your hair, brush your teeth. We didn't capture that exactly, but Should we have? Yes, but with 10 patients, that becomes some could, some couldn't. You have 3 that now could, 2 that couldn't. It becomes a little bit harder to figure out what's going on. Another one, and so pulmonary function we did do at our program in the end, and that was accepted as, and that's partly because I think there's a fairly large history in the asthma field using pulmonary function, so it's not completely unknown as a endpoint in programs. But how to interpret it, what they mean in MPS 1, in our advisory committee, there was a Dr. Jode, who was the pulmonologist there, and she had a tough time how to interpret 4.5% absolute change in FVC in this disease over a 6-month period relative to what it was going to be, and it was a difficult discussion. How do you know what that means? And she felt that by itself it wasn't clinically meaningful, but in this disease where they're going downhill and now you're turning the corner and getting better, it's probably important. She voted with the group that it was clinically meaningful, but she was conflicted in the discussion. Now, another one that came up in our program was airway obstruction and sleep apnea. Out in the world, sleep apnea is, it's a specialty in itself. You get board certified in it. You evaluate patients. They get surgery or they get CPAP or other treatments. There's standards for how much you can have, methodology of how to do it. It's well associated with a whole series of health problems if you have serious sleep apnea. And what we found in our first program is that patients who had sleep apnea at baseline did get better. Their apnea events went down, their oxygenation got better. And in fact, in our phase 3 program, the blinded program, only 50% of the patients had sleep apnea at baseline. But if you look at the 50% that did, we had half were in placebo, half were on drug, and we had a statistically significant improvement in sleep apnea. So they dropped by about 10 events per hour. And that looks significant. But the problem is we haven't really proven how much apnea measured on this test predicts who's going to get heart failure in MPS 1. Core pulmonal right heart failure is the cause of death historically in MPS 1. If they don't get trached and they don't get any other interventions, they will go into have pulmonary insufficiency and get associated right heart failure. But it's hard for us to know how much change of sleep apnea relates to whether you're going to prevent core pulmonal or not in any particular patient. I can say patients on ERT historically now in MPS 1 have not gotten tracheostomies if they've been on enzyme therapy. Normally, the patients often will get tracheostomies, but getting a tracheostomy is highly clinically dependent. Patients don't want to accept it often. The doctors will fail to do it when they should, so it becomes a very difficult procedure because it's so much dependent on medical judgment whether it's happening. So trying to decide, have I prevented people from getting a trach, is a very difficult way to assess a clinical program because there's so many other factors that affect the decision to do it. So, but yet, intrinsically, sleep apnea to me seems quite important because it's part of a pathophysiologic process, but not easily accepted as an endpoint because it hasn't been so readily accepted in drugs anyways. Another one that comes up a lot is heart echocardiograms. And those can have a lot of problems because just like measuring arrhythmias, other things are sort of secondary events. In our MPS 1, in the severe study, the young under 5 study, the patients had a cardiac mass that was 3 Z factors above normal, right? That was the means. And in the study, it went from 3 above normal to 2 above normal. So the heart sizes improved. We haven't really proven whether that changes a risk for heart failure or changes something else. We have case reports of patients who have Hurler syndrome that were in heart failure, couldn't undergo bone marrow transplant, that got enzyme therapy, came out of heart failure, were able to go through a transplant. But those are case anecdotes. But how do we interpret large heart? Is that really intrinsically clinically meaningful or not? Now, I think in the rare disease area that some of these measures that doctors are using and acting on that are physiologic or intermediate clinical endpoints are important because these endpoints actually give us something quantified that we can measure, and they're surrogates, and so there's a lot of issues that come up with them, and if the changes are small, they're not really considered functions and so forth. But I think the point is that they're actually much easier to measure, and so when you're dealing with small studies in heterogeneous populations, they become better endpoints to do in clinical programs than a lot of things that would be considered more pure clinical. And so the advantages are that they're easier to measure, and therefore you can really tell more accurately what's going on. They're quantitative and usually allow you to have sort of continuous variable power, whereas a lot of the other clinical endpoints, like number of hospitalizations, other things, are very non-parametric, have very small event rates, and have then trouble in powering. Some of these measures are actively measured on the patient, so they eliminate effort. Like sleep apnea has done it while sleeping at night, hooked up to machinery. Patient effort's not required. And so they have some advantages. Echocardiogram, patient doesn't do anything, you're looking at the heart and measuring it. So there's some value there not having those other patient-related effort and mood factors affecting just as you heard with the 6-minute walk test. Now, the clinically used, some of these things are used for diagnosis and management. So they have, when I say numbers, it means they're standards for what are expected, and they're standards for what is diseased, and there are standards for what other treatments do in other disease states. So there's a lot of information you can tap into to try to calibrate for your disease, because your disease may not have very much information. But clearly they're not clinically meaningful by themselves. They're not part of what's considered a clinical endpoint. But there's still a challenge here, and if some of these endpoints have been used in clinical programs, then it's an easier path, but there are a lot of others that haven't been that probably I think should be, but how do we get there? Who blazes the trail? Now, in all the MPS programs now, the 6-minute walk test has become like the thing. We talked about this. When I started MPS 1, I didn't know what it was. No one else knew. What I did know, some patients told me, I can walk around the park now. It was this discussion of what was happening to patients on the drug, and they said, hey, I can walk around the park with my parents. I don't walk behind. I'm walking ahead of them. I walked all day at Disneyland. I didn't get tired. I didn't need the chair, the wheelchair, which a lot of kids with MPS 1. And so, the people at Genzyme, in fact, came up, well, why don't maybe the 6-minute walk test would be a way to capture that. That's how we did it. And so that happened in the first study, and it was successful. So then that trail was created, and now everyone is doing, and all the other programs went down that path. And I just think it was like some moment meeting with me and David Meeker, and PK was there, and a couple other people, when we come up with an idea, and then suddenly it's all over the place as if it's now, it's something brilliant. I don't know if it was that brilliant. We just were trying to figure out an answer to something clinical. So I think I think there needs to be some better process here. So when we talk about qualifying surrogates, I think some of these other clinical measures that are closer to being clinical, that are commonly used in practice, should have a better path. We should be able to use them, but that doesn't mean they're good as they are. It means they may not be great assays because they may have intrinsic variability, they may not have been developed well, and you need to figure that out. But assuming you can make sure that they're done well and the assay's right and they're measuring something that's well accepted medicine, I think they should be more available. So they're closer to the clinical endpoint, they're quantitative. And I think the interpretation of clinical benefit is more plausible. That is, if you really are stopping sleep apnea, it's not hard to imagine that you don't need a tonsillectomy and a TNA anymore. You don't need CPAP, for example, eventually. That if you can reverse the course, then for example, sleep apnea, you've made a difference to them clinically, even if it's hard to capture enough events in time with a small study to get there. There's clearly enough criteria for how to diagnose and manage and you should be able to have some ability to assess the change relative to the change seen in other disease states. And let's say if you're talking about range of motion, if a 10-degree increase in MPS, how does that relate to factor VIII deficiency, where originally range of motion was one of the things that was used in looking at joint injury? How do those relate in these situations? How does the sleep apnea index of 10 per hour in MPS relate to what it is in others? Hard to know all that. And how does 4.5% in FVC really compare to other things? So those are some of the questions that certainly remain. But I think because they're intrinsically better than pure biomarker surrogates, they're closer to clinical function. And I think that you can assume that they're going to be more meaningful. But I do think that regulatory precedent has been important, and I think we need to figure out how to qualify and execute these measures more readily, because I think there would be another way to help improve the development process. So I wanted to follow up that muscle strength question with this one. Now, one of the things that the muscle strength question came up at a meeting on the oligonucleotides in neurology, meeting that the FDA and NIH put on a year ago, maybe about a year ago, right? Mark was there. And there was this whole discussion about endpoints, long discussion, the 6-minute walk, and everyone was upset about the 6-minute walk and how problematic it was. And I remember Mark Walton was on the podium there, and the question of muscle strength came up, and for some reason muscle field there was going away from muscle strength, never using it, and Mark said, well, I think muscle strength is still a reasonable thing to do, and so it's certainly been talked about, but I felt like that was another example of a situation where I think we should think that muscle strength makes sense, and calibrating how much muscle strength means how much is something you need to do, but you should be able to figure out that you got a muscle disease, you're measuring the strength. If the strength is improving in several muscles in a disease, that your drug is doing something that's a substantial benefit, but at least sufficient to get accelerated approval, if not full approval. So anyways, I want to stop there. That's all I'm going to talk about, and so we can answer